Hey everybody, welcome back. It's Pre-Hospital Paradigm Podcast. Let's see how today goes. Both of my colleagues here are all hopped up on caffeine, and we're late to the punch here because we've been just sitting here giggling for the last last 5 minutes. So apparently Ray has all kinds of energy for you today. So you're going to get a macro dose of pediatrics from Ray. So hey, I'm Scott Wildenheim. I got Caleb Ferroni to my left here. I got Ray Pace at my right. And returning for our live, Dr. Regina Yaskey.
Hi, thanks for having me.
Rainbow Babies and Children. Thank you for coming back. You were just telling us you hopped off a plane and came literally straight here.
Yes, I did.
And I also heard you got a walking tour of the complex here, and you got to visit all our neighbors.
Visit all your neighbors and the neighboring buildings.
Yeah,
yes.
They're not weird. They're not weird at all. I'm glad. I'm glad you made it here unscathed. Glad you made it here unscathed. But you started to tell us a little bit off air. What you were doing some presenting and you were doing some other stuff.
Yeah, I was doing some presenting. We were at the AAP, the American Academy of Pediatrics. We have an annual convention, and it's where all the general pediatricians and all the pediatric subspecialists. My subspecialty is pediatric emergency medicine, right. But we all get together once a year, and we all, do our presentations. We have mind-body wellness sessions. We talk about, shared best practices and the ongoing research that's going on currently that has to do with pediatrics. So it's a pretty cool conference. It's really great. And the best part of it is you get to see all your colleagues, like people you did residency with, people you did fellowship with, or you went through fellowship with. Like my roommate of 20 years, who I haven't seen in years, was there. So we got to reconnect, which was nice because we met in college and we both wanted to do medicine, and we both went into peds. And she's a general pediatrician. I subspecialized, so it was nice. Yeah,
it's like a family reunion.
Yeah, it's like a family. It really is.
They all wind up at different shops.
They all wind up at different shops.
You get to come together.
It is.
That's a yearly conference?
It's a yearly conference. And last night, my hospital always does like an alumna dinner. So all of the old, I shouldn't say old, but all the former residents, people who trained there, subspecialists, they all came together and we all had dinner together. So it was nice, and it was hosted by the hospital.
Oh,
so
that's
nice.
That's nice.
At the hotel.
That's awesome. So what did you present on?
Cool. So I looked at
just give us the whole presentation all over again.
Right?
Yeah,
so
but it needs to be within the hour time frame.
I'll be very concise.
And dumb it down for the paramedics, right?
Holes and such.
It was interesting. My work was looking at supply chain changes in Midwest hospitals during pre-COVID and post-COVID. Exactly. So it's very interesting. Yeah.
Was the summary like it's all messed up?
No, well, it's getting better. I would say
all messed up, getting better. Got it.
I will say that COVID got hospitals to pay attention.
Oh yeah.
And to realize that they needed to do something.
Yeah, that they needed to solidify that.
And secure supply chains.
Secure supply chains, exactly.
Locally.
Because it was very fragile, and I think, we just kind of took it for granted. And after COVID, it was.
And if you had a graph, it looked like Torsades de Point.
It looked like Torsades de Point. Yes.
I don't even want to admit to some of the crisis plays we had in place during COVID. Just because we couldn't get things. It was,
Oh, definitely. Medications. Oh my gosh. Yes. Meds. And not just that, also stress, the workforce stress, because if the nurses were not getting their medications to treat their patients, they were stressed out.
Of course.
And that also led to burnouts, mental health issues. So it was a lot. Yeah. It kind of there was a downstream effect with it too. So
this is funny. The one the one thing I was going to start with is like, hey, we're approaching croup season.
Yeah.
Let's touch on that. And
there it is.
There's the Eric Pohl. Thank you. There's a dude I haven't seen in a while. Eric, how are you? And
hi, Eric.
so this is if they're not sure if it's an upper or lower airway issue. So why don't we talk about some differentiation there?
Yeah.
And then which agent in which situation?
Yeah. So first, if we're talking about racemic epi and epi, let's just talk about like what Scott said, an upper airway versus a lower airway issue. I always think of an upper airway issue as something that is audible, you can hear, or something you don't have to press your stethoscope like alongside your lungs to listen to, that you can hear.
Audible
It's audible, or you can even put your stethoscope to the child's nose or the mouth, or even put it here across, like against the neck. You should be able to hear what the child is doing. If you have to listen to the lungs to hear it, then that's lower airway. Upper airway is up here. So, for example, stridor is upper airway. If a kid is stridulous, you walk into that room, you will hear that child. You will hear it. That's stridor. And if you feel like it's faint, and sometimes it can be faint, you can just put your stethoscope up here or put it here. You should be able to hear it. Now, wheezing, a lot of parents will tell you, I heard them wheezing last night. Wheezing is actually lower airway. Sure. If you're hearing wheezing, it's probably some what we call transmitted upper airway sounds, because you can only hear upper airway sounds. But wheezing is something you would have to auscultate to listen to the lungs to hear. So that is the difference between upper airway and lower airway. So when we are treating upper airway, the one illness that comes to mind that affects kids with upper airway issues that you would hear stridor for is ding 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 croup, right? And also if you have a toddler who's
we don't even have to add the sound effects.
If you have a toddler who parents come and say didn't have a cold, was fine, didn't have a fever, they were running around or I don't know, crawling around, and now they just showed up and you're sitting there, you're watching NFL Sunday Night Football, and your child shows up all of a sudden has stridor, your little toddler crawling around, and they have stridor. The second most common, foreign body. Exactly. Yep. Upper airway, foreign body. Okay, so those are the things we think about. And like I said before, stridor, you should be able to hear it. It's audible. Lower airway, most common one, we know asthma. In your adult population, it would be like COPD or something. But with little kids, it's, asthma is the most common one that we would see. And those you would have wheezing. And then they asked about racemic epi versus the duoneb. So good question. First one. So racemic epi is a nebulized epinephrine treatment. Racemic epi versus epinephrine, first of all, like the dosage is different, racemic epi versus epinephrine. And then the way you administer it to the child is also different. Racemic epi is given in a nebulized fashion because you want it to get to the upper airway, right? So we put it in a mask and we give it to them this way. And that's for stridor at rest. So that's for kids with croup who have stridor at rest. We give them racemic epi. Duonebs, it's two, so that's albuterol and ipratropium bromide. Duoneb is different. Duoneb is for lower airway. So there are two completely different medications. Duoneb would be for like lower airways, so for like asthma. So if they are wheezing and they are tight, to kind of help the lungs to breathe and open up the alveoli, you would give a duoneb for.
And I think a good way to just approach that is if you're using your stethoscope to treat this, you're going duoneb. If you're not, you're probably going to hit it with racemic epi.
That's a good thought,
this time of the year. And like you said, there's a very easy distinguishment between upper and lower airway problems. It's divided. So anything down here is lower, anything up here is upper. And I think we get away from that sometimes in trying to, what do I hear? What do I hear? If
you're hearing it and you're literally hearing it, it's most likely upper airway. Yeah.
Unless you have like spidey senses.
And I think sometimes we try to overthink it. To like Caleb's point and your point, like if you walk in the room, that's kind of like your first assessment of the child. So if I can hear that child audibly just by walking in the room, I have an upper airway problem, right? Or if I get to the point, I like how you kind of broke it down. If you're using a stethoscope, think lower. If you're just audibly hearing it, think upper. And then I did want to piggyback off on one other thing that Eric asked. It says, what happens if you try to nebulize non-racemic epi? We actually have a backup for that in the protocol, just in case there's a shortage for racemic epi. So I'm going to touch on racemic epi first. If you guys are going to administer racemic epi and you use a university hospital's drug box, remember that epi concentration for racemic epi is only in 0.5 mLs. So we have to add some saline to that, 2.5 or 3 milliliters
a single
of saline.
puff of we've seen certainly had providers do that, right?
Yeah,
just stick that straight in
like,
and it goes,
why isn't it working?
That's all you get. But your point is absolutely well taken, right? You have to dilute it, right?
Yeah,
so it runs longer.
Correct. Yeah, you have to dilute it. You're going to get more bang for your buck. But pay attention to the concentrations because of supply chain demands that might that might change. And one of the backups we put in is you're able to take 1 to 1,000 epi or 1 milligram and 1 ml epi and put it into a nebulizer. You just need larger quantities of it.
All of our pharmacy friends will be happy for you to make that clarification.
Really awesome.
1 milligram per milliliter.
Done, yeah.
1 milligram
1
per
milligram per ml.
But I think I cut you off saying the important part there about the dilution with the 1 and 1.
So I believe if you look at our protocol, it's a backup of 3 milligrams of epi.
3 and
It's
5.
3 and 5.
Yeah. Over and under 10 kilos.
Yes, over and under. I can remember the over and under. I'd have to look just because we're so used to just doing the racemic and adding 2.5 mLs of saline to it. But there you do not dilute it.
And that is a very important point, right?
And we look at it, and I'm sure you could expand upon this a lot better than I can. But we look at racemic epi. It was always taught to me as this is a lot more potent of a drug, higher dose.
Yes, it's a higher concentration.
It's like 14.25 milligrams equivalent or something.
It's
14, 15, I think I round up 15 in my head, but I think like it says right on the
it's
front of the
definitely a higher
package,
concentration.
14.25 or something.
Scott's kind of a geek.
I know.
I am disappointed in you.
You are a geek. I'm sorry.
I am completely through and through.
I think another thing maybe you're about to hit on or not, but it's also the duoneb being albuterol and the ipratropium. One of them's going to make you cough a little bit, and that's kind of supposed to work that way in dry secretions. So we've talked, I think, before that when you give albuterol, sometimes you're hearing wheezing after 2 or 3 doses. It's because it's starting to work. Well, same with giving a duoneb treatment. If you have somebody start to cough, it's probably working.
It's the ipratropium. It's an anticholinergic. It will make you cough and dry up a little
dry. Absolutely.
And the other point too to make off of that, it talks about we're talking about racemic epi versus lower airway problems and given duoneb, and talking about the ipratropium part too is if we're going into our assessment with a pediatric patient and mom and dad are like, well, I've given my child their puffer 3 or 4 times and I haven't had a positive response.
Oh, was it within date? Was it theirs?
We got to run down that gamut.
You have to run down. Yes.
And then we also want to see that's probably just albuterol. So that's why we want to get the duoneb and kind of trick the receptors in the lungs to try to get that medication to absorb. Because if we're just throwing more albuterol at them, it's obviously not successful. So the duoneb is actually very important.
Not to sound like Dr. Spanner, but that's a great point. and I think that's worth mentioning again. Like if it's not, maybe your treatment path isn't working, and the parents have done it enough now that they're concerned enough to call 911. They've probably tried it a few times, and now you're going to have somebody who's very sympathetic and very tacky, and because it's usually just
kinda
an
like
alpha 2, but you do have beta and alpha 1 response there too with that albuterol.
And we talk a lot about that whole that suppression of the anticholinergic, the suppression of the parasympathetic nervous system, allowing the sympathetic drug, the albuterol, to work more. We talk about a lot in one of our other podcast series. So you get that drying, you get that augmentation, you get that that cough piece, all as part of it. So we have a little extra booster for those lower airways, even if they just happen to have an MDI of Prevenil or albuterol or something like that.
Are you finding often in the ERs that even with kids, it's not so much in our protocol, but are you going to CPAP for the asthmatics that you can't bring out of with just your standardized albuterol atrovents? Or
we do, and those usually are the kids who we've kind of gone down the line and they're still having difficulty breathing because, like positive pressure, it helps with your work of breathing, right? It helps with the water displacement and everything and builds more alveoli and all that. But yes, especially, and those are the kids like who are really like in status asthmatic as we're seeing them going into the ICU. CPAP definitely helps. BiPAP.
Yeah,
CPAP.
they're just tired.
Definitely, they're just tired. And exactly. And it definitely like helps lower rates of intubation. I don't remember the last time we intubated an asthmatic kid, which thankfully,
right? No, that's
not what you want.
That's a great, that's a great thing. I can't remember that.
I just think CPAP is so underutilized sometimes. It's such an amazing piece of equipment.
And in the peds world, I've got some exposure specifically at home to the high flow nasal cannula space in the adult population.
Yes.
What's your utilization of that?
We love it.
And what's your trigger? To his point, what's your trigger of putting them on high flow nasal cannula versus putting on
And this
CPAP?
is not a normal nasal cannula with just
right. Oh yes. Oh definitely. High flow. So what we found with bronchospasm and lower airway issues, especially with bronchospasm, those kids do better with CPAP, right? Helping with your work of breathing. High flow nasal cannula comes up with kids who are hypoxic. Oxygenation, exactly. And where do we see that? Season is coming. It's upon us. Bronchiolitis. Yeah. Ding, ding, ding. So high flow nasal cannula is wonderful. When I was a resident, we used to intubate all these kids. Starting in the 80s, increased work of breathing, yes. Then high flow nasal cannula came along, and actually Rainbow Babies was the hospital that did the research. Dr. Rhoda, he's no longer with us. He's now at another institution. But they did the study where they found out, because we used to max out at a certain weight for high flow nasal cannula kids, and now we can go up to 2 per kilo for these kids. So we really have room for even the bigger kids. So it's wonderful. So instead of intubating them and taking away that drive, you can just put them on high flow nasal cannula and just kind of just titrate them in the ICU. And they do very well. And last year, when we had what we call the triple demic of COVID, flu, and RSV, high flow nasal cannulas came in very, very hit. And I think all of the high flow nasal cannulas in the country were being used.
Part of their admit package. Here, welcome. Let's size you for a high flow cannula.
You probably honestly cut way down on pneumonias too with intubation.
Yes.
That's just fantastic.
Exactly.
What about I saw? Sorry, you were going to ask something.
No, ask your question.
Palmodine came out with that new nasal trumpet that's high flow oxygen attached to it. And I thought that was fantastic. Have you seen those yet?
I have not.
I haven't. I know what you're talking about, but I don't know what that...
Not to push a product, but I was like, why aren't we doing this already? Why is this just now?
I haven't seen that one yet.
So I think there was some FDA... You're talking about the consumable HFNC for the field.
Oh, really?
I
so
think
it's
there's
just a nasal trumpet?
There's a flow generator on it. And, I don't think that's ready for prime time. I think there's some FDA clearance, and but there might be some. And I don't know about the peds space, right? What I saw was clearly for an adult, but. But seriously, I mean, if it works in the in-hospital setting, there's probably no reason it's going to fail in the out-of-hospital. You touched on bronchiolitis, and I think from the pre-hospital side, all wheezing is asthma in kids. So suss that out for us. What's your trigger, and where in pediatric specialty is this line, and when should we be more properly? We're still going to come in and say asthma, but when should they more properly, call it bronchiolitis versus asthma?
So you have a very good point. And a lot of times it is difficult when they're younger to really tell, because they do come in wheezing, right? It's lower airway. They do come in wheezing. I tend to think of kids with bronchiolitis like they... I think they sound like a washing machine. They have crackles, they have wheezing. It's just a lot going on in the lungs, just Rice Krispie treats, just everything going on. And I say, I tell my pre-hospital providers, I always say, if the kid is wheezing and having increased work of breathing, it does not hurt to give them a trial of albuterol en route, because a lot of these kids actually do respond, and they may have what we call a reactive airway component to them. It's just that they're too young to be diagnosed with asthma.
Right.
They haven't gone to a pulmonologist. We haven't done the peak exploratory flow test or anything yet. But it doesn't hurt to give them a trial of albuterol. And what I do to ask them, I just say, please auscultate them before and after. So when you do come in and you give them a trial, let us know, did it work? Do you think it made a difference? And someone said, I tried it and we didn't make a difference. And we're like, oh, okay. Maybe we'll just do some oxygen. We'll suction and do some oxygen. Bronchiolitis is one of those where you just try and, and see. But some of them, the albuterol does make a difference, and then you kind of go down that route.
So I heard
so you may just have to, do both.
So
oxygen
and I
albuterol.
kind of heard in that if we showed up on scene and my kid's sick, we were at the hospital 3 days ago, discharged with bronchiolitis, and they're getting worse again. That differentiation really doesn't change our treatment course out of hospital. You still want us to attack essentially whether it was diagnosed asthma, that maybe they're a little older, or they're young and they just come back with bronchiolitis. That shouldn't really trip us up or change anything.
It shouldn't trip you up. Yeah. No, it shouldn't.
That's awesome. Earlier you talked about stridor, and we talked about the two most common causes: the croup versus
the dreaded foreign body. Yes.
Are there any tricks of the trade to figuring out which may be what clues? Let me ask that a different way. What clues can our providers, and as part of their history and physical exam, pick up on this doesn't fit for one versus the other?
Like I was saying, I think just the history, getting a good history, I think helps a lot. If the parents say they haven't had a cold, they haven't been sick, they have had no fevers, they literally were fine 5 minutes ago, and I just saw them, and they're doing
now
this.
They're croupy, right?
And
now they're
exactly. And most of the time, they're like toddlers or infants, like kids who just started crawling, because at that age, everything is edible, right? Everything goes in the mouth. Like we have kids, Legos, everything goes in the mouth. You're just like, oh my god,
quarters,
batteries. Oh yes, oh my gosh,
batteries are bad.
I can't tell you how many incidental findings we find with kids with quarters in the that the parents had no idea they were there.
Yeah. You guys should start a bank and pay back tuition with just the quarters.
So a lot of times it's just history. But if the parents say they had a fever yesterday, or they were coughing, because croup has the stridor, but it also has what we call the barky cough. Like they sound like a baby seal. A lot of times parents haven't heard what a baby seal sounds like. I hadn't even heard what a baby seal sounds like, but I always heard people say a baby seal.
I think the first time you hear it, you
when you remember exactly. When you do hear it, you're like, this doesn't sound like a normal cough. What are you what is that? What is that?
What is that?
And then you hear it, and then you're like, the parents will always tell you it sounds weird. Their cough sounds really loud and weird. What is that? And I'm like, oh, it's croup.
That would be croup.
That would be croup.
If it's not the dog and it's still the kid, then it's probably croup.
What is your stance on steam versus cool air?
I prefer cool air. That's
and I think that's the bigger push anymore. But I still see we'll go to those calls where we've had them over the hot pot
we tried
for
the hot
4
pot,
hours, and it's like
cool air.
Now you've made them into little cherries.
We always had a good response. Like my son got croup quite a bit, and Dr. Zach's our pediatrician. Awesome guy.
Oh my God, he's great.
We always joke about it. And he was
great.
The second time in this episode, this series, he's plugged him. So
he's good.
And failing this, I was just good.
But he is cool doing the virtual doc thing, which I like because they're pretty far away. But no, he's great because we talk about it, and I think you hit the nail on the head there. It's that first sound you hear it, and I make a joke about, is that the dog? Because we put our son to bed, and it was right around that weather change time too. I think is key to think about as well. You get those cold snaps.
Good point, yes.
We got recently, right. And then now it's 60 degrees outside, but at night you get that cooler air. You put him to bed, everything's fine. And then, 45 minutes into it, you hear this just bark, and I'm like, well, the dog's sleeping, so what is that? And then you go in there, and there's, your son, and you could definitely tell it's pretty definitive. But we had a great response, too, cool air. You know, take them
It's
outside.
cool. Take them outside.
A lot of times they'll say put
the window down a little bit. If you're driving in, just put the window down a little bit, or you can just sit. I actually have a friend. I don't think she would mind this, but her daughter, when she has croup, she knows she has croup, so she had a photo where she had her daughter sit outside the house in a chair, and the TV was there, but she knew, so she sat outside because she didn't want to go to the ER. So she sat outside and she watched TV through the window.
Yep. Or you open the freezer.
Smart girl.
Open the freezer doors.
I've heard that too.
They get that blast of cool air. So I've always seen the benefit from the cool air, not necessarily. We've had some parents try that on some runs that we've went on, but I just don't see
just let my ex-wife into the
positive
room.
response.
You get the cool chills.
Halloween is coming up.
Good to see you.
Well, it's been nice knowing you, buddy. You probably should have done that on something we could have edited.
It's all good. I'll take that one.
That's right.
But no, I think the cold air is probably your number. And it's funny because usually the not seasoned medic or basic will have that patient, and it's them getting to the ambulance. They're like, "They're getting better. They're getting better."
Right.
Like,
By the time they come in, they're better.
Yeah, just because you're staying outside.
Yeah,
That's the most benefit you get. And then, we'll nebulize some saline, or if we need to give them racemic epi, it's beneficial. But a lot of times you gain your best treatment from their house to the ambulance. Especially in the
You might not
country.
even realize it.
Yeah.
Seriously, and they don't realize they got better. What happened?
Yeah.
So
Why did we
reports-
call you?
Yeah, what'd you do?
Reports currently say that this is going to be a really bad RSV season.
Yeah.
So
Is that a thing?
That's it's a thing.
It's a thing? Okay. Yeah.
So the CDC just released about 2 weeks ago saying that RSV was coming in from the southeast. I myself have only seen about 2 or 3 cases, and they were sick babies. So I'm hoping for the best, but I'm expecting the worst.
Yeah.
I don't know if it will be as bad as last year's, where we hadn't seen anything like it in like 20, 25 years.
Sure.
So I'm hoping for the best.
So
really
as far
hoping
for
for the
our
best.
pre-hospital care, what is our best routes for this? And not only for it's also us cross-contaminating. If we have an RSV patient and then we go home, let's say to our kids, and so how important is this right now?
So it's droplet. Masking helps. Wearing your gloves.
We have to wear
help.
masks.
I
again?
know.
You'll be okay.
Oh, you're gonna get so much fight though, It's like-
It helps. Wearing gloves, gowns help, but the most important thing would be because it's droplet. It's it's the mask. I don't know much about. I know they have like these new vaccines that they have out for adults for RSV. I don't know much about that. I can't speak much on that. Only for the infants, like the babies. We've always had Synergis, which we give to babies, especially babies who are born premature or babies with underlying congenital issues, because, they're more prone to getting really bad, bronchiolitis from RSV.
And bad outcomes.
So bad outcomes,
right.
Exactly. So, I'm a big proponent for that, vaccinating the babies with RSV. But, kids who have healthy, normal lungs, we saw a lot of sick kids last year. So we're just hoping for the best this year.
But no indication of our triple threat again.
Yes.
Yeah.
Just
not going
hopeful, getting vaccinated. Flu vaccines are out too. So, hoping that the efficacy of this vaccine will be better than last year's.
Yeah.
Because last year's wasn't great. So
Was not.
But it's, it's a toss-up. We all know that's a toss-up too.
That's all vaccines.
It's all vaccines.
Yeah, right.
It's a toss-up. So.
You spoke earlier about incidental findings in the airway. Does that mean that anybody that comes in croupy automatically gets a film, or is that incidental finding just on visual inspection, or?
Most of the time it's on visual inspection and based on like the history that you got. So we usually
my takeaway here is this is clearly something we could do, right?
Yeah.
Is try harder and look,
Yes.
right?
Yeah.
Just be like,
Seek and you will find.
right?
You
Yeah.
will find. If you can look and see it,
Tongue depressor or
kind of
something. Take a
pull
peek.
it out. Yeah. We don't recommend, of course, the blind finger sweep. because you could push it in harder. So, and if there's something in there, but
and that is
otherwise.
amazing to me every time to this day that I'll do a CPR class on the heart saver level. How it's always the one question I get: why did we take that away? Why aren't we behind finger sweeping? It's like one of the most important aspects of me is not to push it further. Why is this so argumentative? It's just funny to me.
Yeah,
But
people
that's
are
the one
not
that they
happy with
always
that. Yeah,
remembered
really,
was
yeah.
It's like
no.
baked in legacy stuff that people
know.
remember.
It's old school.
It's
That's
old
what
school,
they used
yeah.
to do.
That's how we've always done it. Yeah.
Yeah.
It's like a seizure. They're going to swallow their tongue.
Yeah. Where's my wallet?
Put it in their mouth. That's right. Or tourniquets. You got to untie that every 20 minutes. You know?
Yeah.
Let's just keep releasing toxins.
That's what I relate it to. You know, it's like, oh, we should do that. It's like, no.
Ray, I have a bad blood pressure. Grab me those pneumatic anti-shock garments.
And I think to double back to your point too is like Scott said and Caleb said it, and so did you. Is you have to get a good history and a good exam when we're there, right? So what were they doing? So like in my son's instance, well, he's laying in bed, he was asleep, and then boom, this just started. But he's been there for 45 minutes,
right?
Yeah.
Or versus the toddler was crawling around the living room where toys are. So I think a lot of this is just common sense findings, but it's those little things that we could pay attention to try to help us make a better decision.
It's that is the second subplot of this entire pre-hospital paradigm series is the story matters, right?
It does.
100%.
Because I think our messaging on like every episode somehow is medical control's your friend, right?
And story matters.
Right. And somehow we get to the story matters, and it's seasoned professionals that can take even consolidated stories and start sussing out. It's like, well, it's not this, then this. I mean, that it starts building parts of your differential diagnosis for you.
And these are extremely hard stories to obtain sometimes.
We talked about onset, right? That rapid onset versus they've been sick for a couple of days. It's getting worse.
EMS
right?
trigger words.
They should be right.
Yeah. Rapid onset
they should be,
or
right.
age. Or, he was fine a minute ago.
And then,
And do not forget your doorway assessment. Before I even lay hands on that patient, I should know sick or not.
This one's wooden. This one has a window in it. The doorknob's on the left on this one.
Yeah, I call it your PATS, your Pediatric Assessment Triangle. It should be less than 60 seconds. You should be able to look at that child, like you said, your Dorian assessment. You should be able to look at that child and say, are they sick or not?
What are we looking for in the PAT? We always should take a second just to double down on that because it's important.
It's one thing to say it, but it's important.
Right, yeah.
So, your pediatric assessment and triangle, like I just said, the first thing you just look at the child. So, airway, you look at your breathing, and you just kind of like look at the circulation of the child, right? So, first of all, you just look at them. Like, how do they look? Do they look pale? Are they working to breathe? Are they upset? Do they look flaccid to you? Just kind of laying there, hypotonic. Look at their skin tone. And sometimes kids look pale, and that's how they look at baseline. And I don't want to insult any parents, so I always ask, like, is this how they normally look? And they'll say, like, no, or yes, this is how they normally look. The parents will say, they're normally pale. I'm like, okay. And then things like cyanosis, like, are the lips blue or the nail beds, blue, things like that. Just quick assessments. You shouldn't even need your stethoscope. You should just be able to look at the child and just kind of
sick or not sick.
Sick or not sick. Yeah.
We're huge on that. Yeah. So we
Any question?
Oh, do we have some new questions?
Are there any medications? Oh, this is another one.
And what should come first?
Are there any other medications we should give along with racemic epi, and what treatment should come first? Oh, okay, that's a good question. So croup comes in two ways, right? It comes with a stridor and with a cough, or sometimes it just, like you said, sometimes by the time you take the child and put them in the ambulance, the stridor is gone, right? But the cough stays. The cough lingers for days. So if they have stridor at rest, and meaning at rest, because it's a child, they're going to be fighting you, and they may have some stridor with that, that's okay. But if they have stridor at rest, you're sitting there, that's stridor at rest. You would give racemic epi for that. If they just have the cough with no stridor at rest, dexamethasone is what we would give. I believe that's in our protocol.
And if we don't have that particular steroid,
Okay.
can we choose others that we may have?
Like methylprednisolone?
You
How
have
about- we have
you would have
methylpred, yep.
methylprednisolone, yeah.
Yep.
So you would use methylpred, yeah.
Yep.
Yeah.
The
1 per kilo.
And I think
One per
that's
kilo.
important,
One per
too,
kilo,
that
yeah.
if we use that, we tell you we used it, because I don't think you redose that,
We
right?
do not reduce it. It's just one, exactly. Just
So
one.
is there? So I know it's just one of
I
those
always
things.
wondered about that too. Why we don't have Decadron for health.
In the,
Okay.
it's probably just a cross section
It's
of
just a
how many we
cross-section?
see. Cross section
Okay.
of how many we see, right? I mean, we
Yeah.
That wouldn't
we're
be
going to use
price,
we
I
use
don't
so
think.
much more of the in the and that's kind of was the crux of my question. And I don't know that I've ever gotten a great
Is it-
answer in this, and I think it might just be because it's the way it's always been done. But why is Decadron, dexamethasone, more prevalent in the peds than it is in the adults? It seems like all the adult docs
Yeah.
grab the,
Methylpred.
get the methylpred, and you guys all reach for the dexameth.
Decadron, it's easy because it comes in liquid and pill form for the kids, and the dosaging is just easy. It's based on like a weight scale, basically. So it's easier that way, and then it lasts longer too. So Decadron lasts for about 32 to 35 hours. So when we give it to the kid, it doesn't work right away, but we can send them home and it lasts longer. And so even for asthmatic kids, when they're going home, we can actually give them the Decadron there to take home with them to use. And it's just like, and the pills are so tiny.
Or like you said,
that
liquid
a 2-year-old
even.
and
Yes.
Yeah, or
liquid,
liquid, yeah.
and that they can just take them. Like it wouldn't even be, they're so tiny. It's great. You don't have that with methylpred.
John's on the other side of the monitor. He's probably losing his mind. He's like, you can give the methylpred orally too.
Yeah, but
Is
it's
he
not.
back
yeah.
there? I'm surprised he
Hi.
didn't stick his head around and
He's back there.
he only brings that up like every other medical director's meeting.
He's eating the salad bar right now.
Oh, he's camped out over there.
Yes. The question to this is yes and yes. Can I place a tourniquet on a pediatric patient with an extremity wound that continues to bleed even with direct pressure? Yes, sir, you would.
Yeah, we just want to
Yeah,
advise.
you would
like,
place it up on the extremity, but yes, you would. Yes.
sorry, Doc. I was just going to
Yeah.
chime in on that a little bit too. Is we want to make sure that we use a commercialized tourniquet.
Yes.
And we want to make sure that, it's a cat or whatever brand that you guys are using, a soft T, but make sure a lot of people like to improvise, I think, when it gets to kids, and that's where it gets scary. Like, you don't ever want to use
We don't have it, kid.
something
Oh, no,
with
not a
you don't-
cable like that, yes.
Something
You're
that will hurt
right.
them, that'll hurt the nerve endings.
Yeah. That's
Almost
true.
like we surrounded our stuff with stuff to
we could
talk
talk
about.
about.
Stuff
You
to
won't
talk
see
about.
it.
Talk
It's a
about
soft
this
tea.
one.
You can use a soft
Yeah,
T.
you could use soft tea.
But the one thing too is, depending on how small the kid is if
There
you look
it
at
is.
the back of this, this is only going to
Might
go
have to lift it up over the sign there.
so
Yeah.
small.
There you go.
This part is actually where your windlass is going to tighten, and this is picking up the webbing. So this part's only going to get so small around that pediatric patient's arm. So if they're a really little tyke, just make sure you have good capture with this tourniquet and actually stop the bleeding, I think is my main point there. But they make all different kinds of them. And this will work on a very young child. We've played with this quite a bit in TACMed.
I'll tighten it down. You can almost
And we
see.
have really small ones for the really small
And
kids.
I
right?
don't think that's a very common thing out of hospital. Certainly not any service I've been exposed to. Do we have a specific pediatric tourniquet?
No one size fits alls for us.
For
or
most, fits most.
yeah.
This is the most common. Unless is there like a different one you would recommend, or
No,
that you
this
guys
is
use
the
at
one we
Rainbow?
use for stuff to bleed.
Okay.
And they work.
They work.
TXA,
Yeah,
very
yeah.
effective.
TXA, tourniquet.
Tourniquet, yeah.
But
Makes
That was a
sense.
good question.
Yeah, it was a really good question. Yeah, thank you.
bouncing back to some respiratory stuff.
Yes.
One thing I was going to ask. Let's say, and I think it was in Eric's question up there earlier. What if they're a mixed bag? What if you have somebody who is both stridorous with progressive onset? So we actually believe this is a medical, not a a mechanical obstruction.
Yeah.
And they are also clearly wheezing, and we really believe that's not transmitted upper airway sounds. I think it's actually, I've got two separate
So you've
sounds
got
coming
upper
out of
airway,
my
lower airway.
patients. In that certainly not a case I've ever had, but in that I imagine an exceedingly rare case. Where do we start? Do we start with the racemic? Do we start with the albuterol? Will the racemic do some of the lift for the lower airway?
I've actually had that before, and we've seen a few cases of that. I would start with the racemic epinephrine. Yeah. So because you remember, epinephrine also has some effect, right, in the lower airway. So I would start with racemic epinephrine. It was a loaded question.
I just wanted it to go out over the air. So the beta effect of the beta 2 effect.
Yes.
We should also place the pediatric
I literally just looked it up.
Yeah, the beta 2 agonist effects of the epi would come into play here.
Correct. It's still right where we need more of the alpha effect for the upper airway. That beta 2 effect is still present, right? So you're not shorting them if you just started with a racemic,
right?
And if their croupiness got better. I also heard from your previous conversation you wouldn't be objected to then, let's say we had a longer transport time, chasing with some albuterol.
Oh, yes, I would not be opposed to that. Yeah. That's a good question.
All right, I stayed at a Holiday Inn, so I'll throw it out there.
You can Google it too.
It's a rarity, but in the case of epiglottitis.
Yes,
so
Lord.
Let's say that we have an unvaccinated patient or even vaccinated, but so what are we going to do? This is my Hail Mary that I never want to come across.
Yes, please. Call Med Command. Tell them what your concerns are. This is where you call Med Command. And do not, I know because it's a scary one, you're like, okay, I need to put in an IV, I need to get this kid, No, this is one where you want to make the kid as comfortable as possible. So if they are sitting in a particular position and you can transport them that way, where they're safe to be transported, but because epiglottitis is upper airway, right? So your epiglottis is super swollen. So they're going to be opening up their mouths because that's the only way they can breathe. And they sit in kind of like what we call like a tripod position. But it's a very good question because vaccination rates have gone down 20%. So all these kids, because it's the hip vaccine, but now the rates are going down. I would not be surprised in a year or two if we start seeing epiglottitis. The ones that doctors who will tell you, older physicians will tell you, we used to intubate room to room to room because they all had epiglottitis. Wow. It was scary. And in my lifetime, we don't see it at all. Right. We may start seeing that again. So that's a really good question.
And we have a higher instance of the possibility of seeing it in Geauga County because we have a lot of Amish population.
Exactly.
Yeah. So it's not unheard of, but it happens. It's funny because it brings me back to when I was in medic school and my instructor, Ed McCormick. His reply to this was always, they're kings and queens. You got to treat the kid like kings and queens with epiglottitis. Just let them drive the squad if they want to drive the squad.
You don't bug them. These are the kids. You don't say, oh, I need to put in an IV. I need to do this.
Don't mess with them.
You don't mess with them. Call Med Command and say, I have a kid I'm concerned for epiglottitis coming in. Yes. And we call anesthesia. Like, it's one, But that's a good question because even this conference I went to, that was really the discussion that we were having. The rates of vaccination have gone down.
Amazing. And it's so anatomically, I mean, it is so enlarged that I think they call it the thumb sign on the X-ray.
On X-ray because your epiglottis, it's so huge.
All right, super. So here's a situation that's super scary in the adult population, but that patient was stridorous, unwell. You're thinking epiglottitis. Ooh. And now they've completely occluded, or they're not moving.
Like Ludwig's angina.
Ludwig's angina.
They've completely occluded. So surgical airway in a kiddo, right? Yes. I just wanted to make the point that currently the protocol doesn't support because we've got docs out there training right now for true surgical cut down airways, right? Cut the air with a knife. In the adult population, and the protocol does not support that currently in the pediatric population. It's a needle crike.
It's a needle crike
only.
And what we do actually, we also call anesthesia when that occurs. Yeah.
And we don't have that
phone lots of friends.
Unfortunately, but I've always heard, it's one of those scary nightmares. If you're going to make an attempt, make it a good attempt. Make it your best attempt. And
right. Where I wanted to kind of come full circle with that surgical airway or the needle crike piece in the peds. God forbid we ever have to get there. That is something you don't want to be putting together and ad hocing real time, right? And it's super simple. All you need is an IV catheter, right, to do the actual introduction.
It is extremely critical that we understand. And I know this is peds, and I know this is hypothetical, but if we're doing a needle crike, this is for oxygenation only, not ventilation.
In all populations.
In
right?
all populations.
It's buying time for her,
I need to make sure
and her
that
anesthesia friends.
anesthesia is there when I get there to put in something that'll actually tolerate ventilatory support as opposed to just oxygenation.
What I was going to advocate is if people are watching this, thinking through, we talked about equipment a fair amount in the actual recorded version, and I don't know that we talked anything about the surgical airway in the kid because
I think so.
It's like almost pushed back of our mind in the adults, so it's really far back in the kids. But have the adapter off of an ET tube, a 3.0. Depends on what brand you have. Some are 2.5, some are 3.0, but that fits inside of a. Do I have one over there on our board? I can just show this.
Oh, yeah. I don't think you had, but you can kind of explain it better.
No, I thought I had just an airway adapter off of an ET tube.
Negative goes through. Wait a minute, you do.
You do.
Oh, look at that.
Oh, there it is. Yeah.
Yeah, that's a 2.5 or a 3.0 depending on the brand.
Yeah.
This particular brand's a 2.5, and
It'll fit.
that would if it fits, it ships, right?
If it fits, it should. Well said.
You have here, I'll set this here, sharp retainer there, but that'll fit right inside there. You can adapt your BVM to it, and rather than try to cannibalize. There's probably a dozen street hacks to do this. This is the cleanest street hack, but that's something you could easily cannibalize. Have it sitting with a catheter in your airway kit for your
option
kiddos,
too,
right?
if you ran into it, would be to use a syringe and screw this. I'm not going to do it.
Don't disassemble mine.
I won't. But you would screw this onto here, right? And then I would put a 6.0 cuffed ET tube into here and inflate it.
And then inflate it.
And then I
Okay.
could use this the same way.
To just kind of
that's why.
Nice.
But that's a whole
I
other
like
day.
that rides. I think that rides better, right?
It does. It does.
Less pieces for me to forget.
I think Roush actually makes a. Like we use the Quick Tray.
They
actually
make a pediatric
version,
They
which
do,
is
which is a lot like that.
I think
which
that's
is-
But just
that's
the
a 2.
pediatric version.
Here,
okay.
no, here's the. Here,
Except
it's
for
right here.
so this is an adult, but they do make a ped. But I mean, I think if you're getting into either this or you're getting into your needle crike, correct me if I'm wrong. I mean, my biggest thing is anatomy. Right?
Yeah.
You have to
know
find your landmarks, and then this
Yeah.
would probably be the absolute last resort. I mean, we even teach that in adults. This is the
I know.
absolute
You need to know
last
where that
resort.
cricothyroid membrane is. Yeah.
Oh,
I
yeah.
mean, that's just
And if you're going to miss,
yeah.
A good point. So there's another question. If I cannot get an IV on a hypotensive patient, are there other options I have other than IO? Since I know that's going to hurt.
to be honest, I think the IV would hurt more than the IO.
I think so
if we're
too.
flushing it with lidocaine the way we're
it's
supposed to be, it's
yes.
Yep.
I would say go for the IO.
Yeah.
Yes, I know.
honest to God, I think it would hurt less
I
than
think
the
it's the
angiocath.
mechanism. So there's always the thought of drilling. Go ahead, but
No, I'm trying to remember. We talked specifically about this, is the reticence of a lot of providers in the conscious and semi-conscious patients to use
did.
IO in the patients that are in dire need of drugs or alcohol, or drugs or alcohol.
The Browns
That's
won,
the
bud.
provider. The provider's in dire need of drugs or alcohol.
Dr. Hill just walked out laughing.
Yeah, I know. I saw this. Is
Wernicke's
fantastic.
and stuff.
That are in dire needs of drugs or fluid, right?
Yeah.
Is the reticence of somebody, and we really talked about, we were pushing that whole using the lidocaine to numb up that interosseous
Yeah, we were
space. and
talking
how
about
it's-
if you had an unconscious patient, sometimes you'll wake them up just flushing it without the lidocaine.
I think that was some bonus material that we haven't released yet. So if you want a whole bit on this,
Yeah, that's fine.
I think
Good.
that it's November or December. We've got a whole extras bit coming up
On that.
and it expressly talks about this, not in the peds population, just in patients
But does-
in
In
general.
general.
Does
Yeah.
Arrow still produce easy IO? Is that Is that still Arrow? Or
whoever they are this
if
week.
you go to their website, they have
They flipped to, I think, Teleflex.
Teleflex.
Yeah,
Teleflex.
So Teleflex, if you go to their website, they have
Good
hours
videos.
of video
They do
of
have good
doctors
videos.
inserting IOs on conscious
Oh yes, you can even
volunteers,
find
believe it or
them on,
not,
yes.
and without problems. Even taking them out. Now it's the flushing that gets you, but that's why we have lidocaine. And if we're flushing it with lidocaine the way we're supposed
Correct.
to be,
Correct.
it's going to be fine. And I'm telling you, I think it hurts more to do an angiocath than probably an IO.
Yeah.
Yeah. It doesn't even scan. It doesn't stand to reason that there's not pain receptors in bone, right? It's pressure receptors
Pressure
in the
receptors.
interosseous space that's really what hurting them, right?
And when I say push the
Just seems so
lidocaine, don't
barbaric,
slam it.
right?
Nice
Slowly.
and slowly let it absorb.
Let it get in there.
Or pop.
I'll definitely say in a child, a hypotensive child, a septic child, and you can't get an IV, please put it in an IO. Yeah.
And what are signs, the very, very little babies, the fontanelles and all that, but the signs of hypoperfusion or hypotension?
Yeah, like you mentioned, like if it's an infant, obviously, like the flattened fontanelle. I always say, like with kids, they're going to tell you. So if this is a kid that was normally energetic, the skin is usually dry, the eyes are sunken in, the mucous membranes are dry, and they're just not as interactive, right? That's one of your assessment tools.
Ask
your
about
pads.
diapers.
Yes. Biggest one, urine output, right? If the parents say like they haven't made a diaper in over 24 hours. Yeah, I always say in babies what comes in goes out. So if the parents are like they haven't peed in like over 24 hours, that's concerning. 12 to 24 hours, that's concerning. Exactly.
I just thought of this.
So.
What about, and this is one that usually doesn't come up, what about bulging fontanelles?
Yeah, so bulging fontanelle is actually the opposite. One would be like, hypotension. They're, not just hypotension, but they're dry. Basically, I shouldn't say hypotension. They're dry. But bulging fontanelle is most of the time it's a sign of maybe like an infection or like an increased ICP. Something is going on in that brain that brain doesn't like, right? So it's swelling up.
And unfortunately,
so
I think one of the medic chapters pushes hard that that's a good sign of child abuse, is a bulging fontanelle.
Yeah, that's one. In little ones, if by the time you get to a bulging fontanelle in a kid with child abuse, a non-accidental trauma, you should be seeing other signs with that child, and they will not be signs that you like to see. They will be scary. But the most common signs that you would see with kids with child abuse would be like cutaneous findings, things like bruising and things like that. Burns, but if you do see a bulging fontanelle in a kid that's not acting right, they're altered, yes. Non-accidental trauma should be high on your list there as well.
No, that's a good point. It's a little more obvious in the kiddos than it is in the adults.
Right. Oh, definitely.
Everything's so soft.
Well, we always talk about sunken fontanelles. We don't often talk about
the
bulging.
bulging.
That's a point well taken.
And there's more than one fontanelle. People don't often
there's an
think
anterior
either.
and a posterior, right. The anterior closes later, so that's usually the one that we go for because it's around till about 6 months of age.
You just teach that chapter in the book.
I know. Yeah, because I always feel for both when they're really, really little.
I'm Googling it, man.
No, get your hands up. These are my answers.
Let me ask a question.
What are pediatrics?
This is UH, man. We just know this.
Yeah. Circling back to that IO question.
Yes.
Humeral heads in kids.
Yeah.
Not only that, but growth plates.
Humeral heads in kids.
Yeah.
Let's start there.
Uh-huh.
Is there a well-defined, again, tongue-in-cheek here, but is there a well-defined transition where it's appropriate to use them in kids versus infants, or
I would say in older kids.
We press it
humeral
so
head
much
in
at the
older
adults.
kids. Humeral heads in older kids. Proxima tibia, distal femur, and usually like the younger ones. That should be okay. Older kids, 12 and over, you can even do the sternum. That's been proven to work. That's
iliac
fine.
crests.
Iliac crest. That's more difficult. You can, but the literature shows proximal distal tibia, distal femur, which we normally don't do distal femur in adults. proximal humerus, and then you can do sternum if they're adolescents.
We're going to now enter a very special phase of our recording.
Okay.
This is new. We're saving this only for you. This is a doc ask a doc session, right? And Dr. Hill says, do you have any good memory techniques to remember normal pediatric vital signs?
Oh gosh! Oh boy!
If the heart rate's low, we go.
Dr. Hill is standing behind the camera with a notepad ready to take this down.
I'm trying to remember just the basic ones. I do remember that in the little ones, it's okay to have a heart rate. If you're an adult doc, if the little ones, it's okay to have a heart rate greater than 100, but not a greater than 120. So you stop at 120. If you're getting to 200s, you're in trouble. I think every doctor knows that.
Fair, right.
You're in trouble. And then the magic number is 60. If you're below 60, as you would with any, you're in trouble there. So, but by the time the child reaches like age 10, their vitals should be comparable to an adult's vital. So don't let that freak you out. A 10-year-old's vitals should be comparable to an adult's vitals. And then if you're talking about vital signs, you're looking at blood pressure, right? So a kid who's sick, kids stay sick for a long time. They compensate very well. The first sign you would see with compensated shock would be what? Tachycardia, right? Their heart rate goes up. So their heart rate goes up. That's okay. The first sign you would see with decompensated shock is what? Hypotension. If you're dealing with a kid and you get to a home and that kid is hypotensive, you are in trouble. You are behind. You are in trouble. And how do you check a systolic blood pressure for a child? It's 70 times 2. It's 70 plus 2 times the age, excuse me. 70 plus 2 times the age. And then when you get to 10 years of age, you go back to 90 or less. A systolic blood pressure of 90 or less would give you the kid is hypotensive. But it's 70 plus 2 times the age.
Yeah, and when you forget that mathematical formula, right? Because I have mental block about all mathematical formulas, right? When you forget that, shameless plug out to our colleague Bill Bernhard.
Oh yes.
Who is the guy that took all the time to take every single drug that is in our protocol and bake it into those medication charts in the back of the protocol. And there is a box that has, those systolic targets for that particular weight range, or those fluid resuscitation metrics for that range. It's all baked out. When you forget it, when you're
can't find your PD wheel, or you can't find the app on your phone for all those sorts of things. It's in the protocol.
It's baked in the protocol. All right, we got. I think since we started,
is there any concern to giving TXA in pediatric patients younger than 16 years old? No. So, earlier literature they were giving for kids like 12 and over, but it's actually shown to be safe. The dosing is just different for younger kids. So, of course, it's the same thing. Best effective within the first hour, but you can give it up to 3 hours. And the dosing is just, I don't remember the dosing, so don't quote me, but the dosing is different for kids versus adults, but it's safe to give TXA. I believe you just have to call Med Command.
And Med Command, that was going to be my, it is red box. Yep.
Right, it's red box, but you can give it, yes.
Yeah. Just call with...
You just have to call.
Call with your plan and what you're seeing and what your triggers are. And, and go from there. All right.
Good question.
Hey, that was we burned up an hour real quick.
Oh, I thought it was still 5:30. I'm enjoying this. Okay, I thought it was still 5:30. Okay.
If anybody has questions, you got about 15 seconds to start racking us with them, because we were starting to shut this down. She's got jet lag from.
I feel fine. This is great.
So,
thank you
Dr. Yaskey,
so much.
Thank you for coming back.
Thank you.
I think you have promised us to talk about pediatric poisonings at some point, specifically, mono agent poisonings.
The one pill can kill.
One pill can kill. We'll circle back around and hopefully get that. Let's make that a goal for an episode sometime in 24. Right?
That'd be great.
We'll get you back, get that recorded. So,
thank you.
Hey, everybody! Thank you for joining us here. And if you like this content, and all the backstory and all the notes that go along with us, with this episode and all the other episodes. That's prehospitalparadigm.com. That is the one-stop shop for all of our free open access medical education from the UH sphere, which of course includes these podcasts and our Pharmacy Fridays and our Medical Director Mondays, and again, shameless plug for Dr. Spanner, Dr. Singer, who were doing their great cases. I mean, that was just you and I were talking about, and he was reading. That was a really good case. We've got some.
I just plugged that today in class before I left. Was that case?
Both cases where EMS just did stellar care, or there was something that EMS could take away from a case that maybe wasn't completely obvious at the time, right? Because we can look at the outcomes, right? All of that is prehospitalparadigm.com, and of course, if you like this content, like us on Facebook and follow us on YouTube, and that is starting to roll off my tongue like it's my job.
Share
and tag and all that.
I'm going to call them out. Suzella is on here a lot. Start getting your friends.
All right. Thank you all, and have a great night.
Thank you so much. Thank you. This was great. Hey.